Hello, everybody. I'm Kaylee Paulsgrove. I'm one of the speech therapists at Seattle Children's Hospital here in Seattle, Washington in the US. And I'm going to be talking today about speech therapy techniques to treat cleft-related speech disorders. Ideally, you would have already listened to Olawumi Ibatayo's introductory lecture on speech and language development in children with a cleft palate. And you will have already listened to my other lecture about differential diagnosis of velopharyngeal dysfunction. So identifying VPI versus velopharyngeal mislearning. This talk today is really going to focus on velopharyngeal mislearning. So to give us a review, velopharyngeal dysfunction refers to any problem in the palate closing against the back of the throat for speech. And the two most common types of velopharyngeal dysfunction are velopharyngeal insufficiency and velopharyngeal mislearning. As we learned in our last talk, velopharyngeal insufficiency is a structure or an anatomy problem that can only be corrected with surgery. Whereas velopharyngeal mislearning is related, it's a speech disorder that is only treated with speech therapy. And so that's what we're going to focus on today. When a child presents to you for speech therapy and you know they have velopharyngeal mislearning, then we've got a few goals of therapy to keep in mind. What we want to do, what our job is as a speech therapist, is to teach the child correct articulatory placement or correct pronunciation. We want to teach them new ways to make sounds that replace the old atypical habits. And we want to teach them to direct air into their mouth and build up pressure in their mouth as much as possible. This last part, this last goal is really important to keep in mind if the patient also has VPI, because we know that our therapy cannot fix VPI. And so we just want to work on articulation and placement and know that VPI will be corrected with surgery later. So when you have a child who has velopharyngeal mislearning on your caseload or you're seeing them for therapy, where do you begin? Often the first step in speech therapy is to teach airflow awareness and articulation awareness. What I mean by this is you want to train the child or train the patient's ear to identify when they're saying sounds correctly and when they're saying sounds incorrectly. And you want to model some of those incorrect sounds and correct sounds to them so that they practice identifying it in your speech and in other people's speech. This involves really explicit teaching of where and how the speech sounds are created. And so I will often teach my patients that our lungs are the power of our speech, and that's where our speech begins, and that air travels up through our lungs to our voice box, which is our motor, and which gives our speech sounds noise. And then I'll talk about some sounds being in our nose, like and some sounds are made in our mouth, like ba, ba, ba. And all of this information is really key for the patient to understand. Otherwise, they might not be as successful in therapy. From there, once I feel like the patient has a good awareness of airflow and their auditory discrimination is strong, then I will usually start treating the most visible sounds. And what I mean by that is that I want the patient to be able to see the sounds really easily that we're working on early on so that they feel successful early on. I like to start with sounds that are made in the front of the mouth, and I tend to work my way back from there. So I'm often starting with sounds produced with the lips, such as P and B, or if I'm working on the longer sounds, I'll start with F, V, or the TH sound. And then I'll work my way back as the child masters those. And next we'll work on the sounds made at the alveolus, like T, D, S, or Z. And then we'll keep moving backwards once those are mastered, like sh, ch, j. I'll always save K and G for last. Sounds that are made in the back of the throat are harder for patients to see, and they also involve the velum, and those can be trickier sounds for individuals with clefts to produce. From there, I will often start with whatever sound the child is able to produce the easiest. So if I try some of the front sounds like P and B in therapy, but they're not able to produce them very easily, but they are able to produce a T and a D, for example, then I'll start with T and D because those were produced more easily by the patient, and I will just start with those sounds and then make my way back to the other sounds as appropriate. So there really is no clear hierarchy of which sound should be worked on first, but these are the general principles to follow. The way that therapy should work is that you're explicitly teaching the child the place, the manner, and the voicing for the speech sounds that they need to work on. And we're going to talk a lot about place, manner, and voicing today. I like to give the new speech sounds a new name because it helps the child or the patient learn that they're making the sound in a new way. If you tell them, hey, we're working on our P sound, but their P sound has always been produced down in their throat as a glottal stop, then they will associate that the P sound with that old habit. So what you want to say is, we're working on a new sound that you've not done before. Don't worry about that old P sound. We're making a sound with our lips together, our air flow popped on our lips, and our voice off. It's pa, pa, pa. And that way you've given them a new fun thing to try, and you are not going to encourage their old habits. In your therapy session, you want to get your patient to produce the sound the right way. And once they're able to produce it the right way, you want them to practice that as many times as possible so that it becomes more automatic and they're able to do it more consistently. A really important thing to know about speech therapy is that it is task specific. What that means is that in order to get better at making the P sound, you have to get your lips together and practice the P sound. In order to get better at saying the word shoe, you have to practice saying the word shoe the right way. So activities like sucking or blowing exercises, playing whistles, or any different kinds of massages or stretches, those do not improve speech. And so there's really no point in doing them in our therapy. Once you have taught the child how to say one of your speech sounds correctly, then you continue up the speech hierarchy. Olawumi did a really nice job explaining the speech hierarchy, and so I'm not going to spend much time here. But I do want to say that when the child or the patient is practicing the sound in isolation or the sound by itself, pa, 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 you want them to be able to do it with 100% accuracy or do it correct 100% of the time before you try to turn it into syllables or make it more complex, because otherwise it's not automatic enough to move up to the next level in the hierarchy. If you are using nasal occlusion or nose plugging as a therapy tool, then you do want to have a plan for getting the child to not rely on nasal occlusion to make their speech sounds. And so I often try to get the child to stop using nasal occlusion at the syllable level before they start producing those sounds in words. The airflow control and auditory discrimination area is really important, and it shouldn't be underestimated. Sometimes people think that we are practicing blowing or practicing putting our tongue out and that it's strengthening, but that's not the case. These kinds of activities are educational. They're not intended to make the palate stronger. And we know that VPI and mislearning has nothing to do with the strength of the palate. What we're doing when we're having the child listen to our speech sounds or practice putting air in their mouths while blowing is we're teaching them what we mean by airflow. If we said that our airflow starts with our lungs, sometimes kids need to be taught what that is. And so they'll blow on their hands or they'll blow a bubble in order for them to see and understand what we mean by airflow. It really is all about building the patient's awareness of their own speech sound errors and their own speech mechanism. All right, so now I want to start talking about strategies. So therapy strategies are things for the speech therapist to try when they're with a client in order to get them to say the sound correctly. And this might sound really easy, but it's really not. It can be a major challenge in order to get the client to produce the sound correctly for the first time. And so for each of these strategies, I want us to think about place, manner, and voicing. So where are the articulators? What are they doing in order to make the sound in the right place? The manner referring to how is the air being squeezed or stopped? And voicing, meaning is our motor or is our vocal folds vibrating or are they off? So if you're working on any of the stop sounds in speech therapy, so P, B, T, D, K, or G, here are some techniques to think about. First of all, we need to know the place, manner, and voicing for all of our stop sounds. For the P and the B, they're almost exactly the same sound. Your lips are together, your air is stopped at your lips, but the only difference is that the P is a voiceless sound, p, 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 where our vocal folds are not vibrating, and B is a voiced sound where our vocal folds are vibrating, b, b, b. The next group of sounds, T and D, are the same way. So these are pairs of sounds that share the same place, the same manner, and the only difference is our voicing. T and D are produced with the tip of our tongue up behind our teeth. The air is stopped at the tongue tip. Our voice is on for D and it's off for T. T, t, t. For K and G, the back of the tongue is up against the velum. The air is stopped at the back of the tongue. The voice is off for the K sound and it's on for the G sound. So once you understand where the speech sounds are being made and how they're being produced, it's time to teach your client. So when I'm working on these stop sounds, I'll start with the baseline skills of airflow control and auditory discrimination. I'll often have a picture of a face and we'll talk about our nose, our lips, our throat. We'll talk about our lungs and we'll do some practice sessions where the child is practicing hearing for the targeted sound in my speech. So if we're working on P, for example, I'll read some sentences and I'll say, okay, raise your hand every time you hear that p, p, p sound. Are you ready? And then I'll say, a puppy, oop, and they'll raise their hand because they heard it. Ate a pie, oop, they'll raise their hand again because they heard it again. And we'll say, yeah, there were 3 p sounds in that sentence. Puppy ate a pie, and we're just bringing their awareness to that speech sound. We'll also spend some time talking about what the air is doing when we say that speech sound. So I'll have them hold their hand in front of their mouth and say a sound like H, for example, and I'll have them feel that, and I'll say, do you feel the warm air on your hand? That's our airflow, and we want our air on our lips for that P sound. Once you feel like your client understands those concepts, it's time to start working on the sound. So one of my favorite techniques to do is to give some visual clues and some tactile clues to how to make the sound and add it to my model. So I'll produce the sound, pa, pa, pa. And if the child is not able to imitate it right away, I'll have them feel their hand or hold their hand in front of the mouth and say, feel your air while you put your lips together. Pa, pa, pa. You can do the same thing for T and for K. Those voiceless stop sounds produce a nice amount of air on your hand when you're holding your hand in front of your mouth. And so the client should be able to feel that really nicely. Sometimes if the child doesn't like to feel their air, I might have them hold up something lightweight in front of their mouths while they try to say the sound. So a cotton ball or a feather or a piece of tissue, you can hold that in front of the mouth and have the child pop their lips, and it will move kind of like you see in this picture here. And that can be really fun and a really good way for the patient to see that the air is supposed to come out of their mouth when you're telling them to get their lips in the right place. Another strategy that I like to use is called shaping. So shaping means you use one sound or one thing the child can do successfully, and you try to make it into another sound. And so when I work on P, for example, I might use H to shape it. And so I'll have them make the H sound, And then I'll say, all right, you felt your air. Now let's catch that air with our lips. And we'll say, and you're able to help them make a P that way. If you're working on a T, you can ask them to make an H and then catch the air with their tongue tip. So, and then you're able to help them make a T. Another shaping strategy that I like to use is have the patient just puff their cheeks together, hold their breath, and then release it from their lips. And if they're able to do that enough times, then you can start saying, do you feel the air on your lips? Do you see that your lips are together? For many of these sounds, I'll have the client using a mirror so they can see what their mouths are doing when they're making the sounds. I also like to shape new sounds using nasal occlusion or using a nose plug. And I will just have the patient plug their nose themselves, or sometimes I'll do it for them if they need help. But if you think about the place, the manner, and the voicing, many of our patients are able to say M's and N's and Ng's, the NG sound, really successfully. And we can use that success to try to teach them how to say a new sound. So if the child is really good at making the M sound, you can have them hold out the M sound and then plug their nose, and it turns into a B. So it might sound like B. And that is a good way to teach the child what the air pressure buildup in the mouth feels like and sounds like. But you will eventually have to teach them to make the sound without using their nose plugged once they're ready in therapy. You can do the same thing to create a D sound from the N. So hold out the N and turn it into a D. And sometimes I will do this with K's or G's too. Whatever strategy you use, once you're able to get the child to produce one of the sounds correctly, then have them do it as many times as possible so it becomes more automatic. If you have a child who's really good at voiceless sounds or those quiet sounds such as P, T, or K, you can just teach them how to turn their motor on and turn the P into a B, for example. So I'll have my patients fill their neck and say the sound quietly, pa, pa, pa. And then I will ask them to turn their motor on and make it louder, ba, ba, ba. And this can be very successful. You can do the same thing if they have the voiced sounds, asking them to turn their motor off and make them quiet. All right, our next group of sounds are our long sounds, fricatives and affricates, or our sibilants. These sounds involve a continuous stream of air through the mouth. So the F and the V are our dentolabial sounds, where our teeth are over our lips. They are the same except for the voicing, just like our pairs of speech sounds on the previous slide. So with the F and the V, you've got your teeth over your lip. You want smooth air over the lip. Your voice is off for F and it's on for V. S and Z involve your tongue tip behind your upper teeth. You want smooth air over the tongue, the voice off for S, and the voice on for Z. The SH, you want the lips to be a little bit round with the tongue blade or the fat part of your tongue against the palate. You want smooth air over the tongue and voice off, shh. For our ch and our j sound, you want almost the same placement for the SH, except for the difference is that it's a burst of air over your tongue. So I like to call these our choppy sounds, where you say ch. So it's not a long, smooth stream of air, it's more choppy. The voice is off for CH, and it's on for J. Oh, that's an error there. The TH, which I know is not present in all of the languages that are represented, but the TH, you have your tongue between your teeth, smooth air over your tongue. Your voice is off for one of the THs, like breath, and it's on for the other TH, like the. A lot of the same strategies that we talked about with the stop sounds apply to these fricatives and affricates. You first want to start with your baseline skills, having diagrams, teaching the patient what mouth air and nose air is, and training their ears to hear the sounds correctly. I also use a lot of shaping, meaning I use whatever sounds they have and I will shape them into whatever sounds they don't have. So I often say that I'll often have the child put their tongue out and work my way back. So I'll start with like the TH sound and then we'll slowly work our way back to the other sounds. So for example, we'll start with the TH and then I'll say, all right, let's pull your tongue a little further back, right behind the teeth. And then it sounds like an S and you say, yes, good job. That's the sound I'm listening for. That's your snake sound. If you're trying to get them to say an SH, you can do the same thing where they start with their tongue out, air over the tongue, and slide the tongue back until it's in the right place. And you might have to remind them, oop, look in the mirror, make sure your lips are round, for example. Sometimes kids will have, or your patients will have the SH sound, or they'll have one of the long sounds where the tongue is further back. And you can do the opposite, where you'll have them produce their sound, and then try to get them to push their tongue forward until it's in the right place. So that would look like this. So they're pushing their tongue forward until it's in the right place for the S, and then the sound turns into an S. One of my favorite strategies to use, especially early on in therapy, is once I've taught the child how to make a T sound, then I will tell them to make it long. So we'll do a lot of little T's like this, and then we'll hold it out. And that's when I'll say, that's the sound I'm looking for. It sounded long, your tongue was up, let's make it again. And once they're able to do it once, you just try to get them to do it as many times as possible in the correct way until it's automatic. I also use a lot of visual and tactile cues to emphasize the air. So that means you want the child to feel the air coming out of the mouth, see the air coming out of the mouth as much as possible. So I'll have them hold their hand in front of their mouth while they say shh, so they can feel the warm air coming out of the mouth. Or I'll have them say their sound into a straw or some other small tube because it sounds really nice when the air goes into the tube, and it can be really rewarding for the patient. Often we'll catch our air, especially with the younger children. You have to kind of meet them at their level and make it fun. And so I will have them say their sound and then catch it, like into a straw or into a tube. Another strategy that I like to use when teaching these sounds is nasal occlusion. This really is specific to kids who are using nasal fricative errors. So we talked about those a little bit earlier. Nasal fricatives are when the child may or may not have their tongue in the right place, but they're definitely putting their air in the wrong place. So they are actively pushing the air into the nose instead of the mouth. If you plug their nose, it does not let them do this. It will make it kind of feels uncomfortable because their ears will pop because we've blocked the path of air that they're trying to use. And so it completely blocks that path, and you can say, oh no, your air got stuck in your nose. Remember, it's supposed to be on our mouth. Let's try again. And then they'll be able to get their air in their mouth that way. Nasal occlusion or nose plugging is also a really helpful tool if the child also has VPI. And so you can have the child plug their nose to get rid of VPI while you work on the place and the manner and the voicing in therapy. That way their speech will still sound hypernasal. You might still hear nasal air emission, but they'll have the correct articulation, and that will help us understand their speech and make for a more successful surgery, VPI surgery later. This is an example of how I like to have kids plug their nose, just because they're able, you're able to still see their mouths, but sometimes they'll plug their nose with one hand, and that's okay too. So in summary, the most important things to take away from this talk is that speech therapists have got to be familiar with place, manner, and voicing for all of the speech sounds that we're working on, especially those pressure consonants. You really need to complete a thorough assessment or a thorough evaluation so that you know which sounds the child has correct and which sounds they need to work on in speech therapy. In general, I like to start with sounds that are produced at the front of the mouth and work our way back as we progress in therapy. And sometimes you have to try different techniques. So holding your hand in front of your mouth while asking the child to say p, p, p doesn't always work. So you have to trial different strategies to see what works for that specific client. And last of all, it should be fun. This therapy should be fun. You don't have to have toys or any kind of fancy games, but if you're just act silly and let the child know that you know that they're working hard, then it's a really rewarding experience. Again, thank you so much for listening to this talk. I'm happy to answer any questions via email, or I'm looking forward to chatting with everyone live during our live Zoom sessions and during the Ask an Expert panel, where you'll have other therapists to share ideas with too. Thank you.